Good evening, everyone. Welcome to the Marion Minor Cook Athenaeum. My name is Miriam Farah, and I'm one of your Ath Fellows for the school year. This year, the Supreme Court overruled Roe v. Wade in its decision in Dobbs v. Jackson's Women's Health Organization. Currently, at least 13 states have laws restricting abortions in some capacity, and the fight over abortion access still remains in many other state courts. About half of states are expected to place some ban on abortions. And historically, the Catholic Church has been vocal in its opposition to abortion and other reproductive rights, such as the access to contraception. In the early 1970s, two Catholic organizations, the United States Conference of Catholic Bishops and the Family Life Bureau, led the anti-abortion movement. And after the Roe v. Wade decision, Catholics established the National Right to Life Committee, which eventually became the largest anti-abortion organization in the US. The committee has spent millions of dollars in campaign contributions to mostly Republican candidates. And for this reason and many other reasons, religion has long influenced politics, especially in healthcare. The connection between religion and healthcare is especially important, considering that today, 1 in 6 patients visit Catholic hospitals, and the number of Catholic-owned or affiliated hospitals has increased by 22% since 2001. To better understand the intersection of reproductive rights, religion, and healthcare in Catholic-owned hospitals, tonight we have with us Dr. Lori Freedman, who will discuss how reproductive healthcare is shaped by our social structure and medical culture. Specifically, she will explain how institutional policies for reproductive healthcare can be secret, malleable, and even obstructive to patient autonomy and well-being. Dr. Freedman is currently an associate professor of obstetrics, gynecology, and reproductive sciences at the University of California, San Francisco. There, she's also a sociologist and bioethicist in a program called Advancing New Standards in Reproductive Health. She has published in multiple outlets, including various newspapers, has a book titled Willing and Unable, Doctors' Constraints in Abortion Care, and has published several articles about reproductive health care in Catholic hospitals all around the country. Next year, she will be releasing a new book titled Bishops and Bodies, Reproductive Care in American Catholic Hospitals. And in this book, she will discuss how conscientious objection in medical practice operates at an institutional level, and specifically how new state abortion bans pose many dangers in the medical field. Before getting started, I just wanted to remind everyone of 2 things. 1, wearing your mask indoors while not actively eating or drinking is highly encouraged by the college. And 2, please take this time right now to silence and put away your cell phones. And please remember that both video and audio recordings by the audience are strictly prohibited. Now please join me in welcoming Dr. Freedman.
Thank you so much for that really thorough and excellent introduction. Thanks for that background. So I'm grateful to the 8th for making moments like this possible. It's really actually quite special these days to have genuine in-person sharing of ideas that are supported by facts and research. And it's an honor to be in such good company, so thank you all for dressing up tonight. So I'm talking today about how my book project on Catholic health care in the United States sort of intersects with this uncharted time in our history regarding abortion. As Miriam said, on June 24th of this year, the Supreme Court overturned Roe v. Wade in what is referred to as the Dobbs decision, opening the door for states to ban abortions. So here's a simple overview of what I'd like to speak with you about today. The first half of my talk will cover some basic information about abortion in the US and in Catholic hospitals. And then I'll discuss what Catholic hospitals teach us about how American medicine operates when abortion is not allowed. So I'm a sociologist and a bioethicist. Sometimes people think I'm a doctor, but I'm not. But I liked being called doctor, and I'll take it. And I do work in a medical school, actually. I'm a professor of obstetrics, gynecology, and reproductive sciences. But my research group is located in Oakland and has a mix of social scientists, including anthropologists, psychologists, sociologists, public health researchers, and physician researchers. So we all ask and research different questions related to reproductive health, but with different methods and different foci. So abortion is an induced termination of pregnancy for any reason. Abortion can be induced with medicines or by having a procedure. It is also very common. 1 in 4 women in the US will have had an abortion by the end of her reproductive years. And abortion is probably as old as pregnancy itself. So who has abortions in the United States? Some of you might know someone who did. Some of you might think you don't, but you actually do, because people are often private about their abortion experience, given the intensity of the conflict and stigma surrounding it. People who have abortions are diverse. About 3/4 of them are poor or low income, and 59% are already mothers at the time of the abortion. And even though there's a lot of religion-based opposition to abortion, in fact, patients come from all religions, as you can see in this pie chart. Catholic people are actually slightly overrepresented, despite deep opposition from the religious leadership. While Catholic people make up only about 22% of the US population, they make up 24% of those who have abortions. And furthermore, 98% of sexually active Catholic women have used contraception, despite opposition from the church. So religious background does not necessarily predict the reproductive experiences and preferences of individual people. Abortion is very safe. A person is 14 times safer having an abortion than carrying that pregnancy to term. And complication rates are extremely low, lower than removing wisdom teeth. While conflict and disagreement about the ethics of abortion are common, those who oppose abortion have claimed it is unsafe and bad for people physically, mentally, and emotionally over the years without evidence. To address this misinformation and definitively assess the impact of abortion, Diana Green Foster and colleagues at UCSF conducted a large study. Specifically, they compared how having an abortion or being denied a wanted abortion impacted people's lives. They followed over 1,000 women throughout the US, comparing the health and well-being of participants and their children over 5 years. And they published over 50 scientific papers in top peer-reviewed journals. Their methods involved recruiting women at the time they sought an abortion. Some of these women were slightly too far along to get in their pregnancies to receive the abortion at the clinic they visited, and thus were turned away, while others were just under the clinic's gestational limit and received an abortion. For 5 years, they interviewed them every 6 months to ask them questions about their physical and mental health, their finances, their family relationships, and career aspirations. The women who received and the women who were denied their abortions were demographically the same when they entered the study. All the ways in which their lives diverged can be attributed to whether they got the abortion they wanted or not. The Turnaway study showed that when people can get the abortion they seek, they and their existing children and future children do better along several health measures for years to come. They're more financially secure, their physical health is better, and they are less likely to be tied to a violent partner. And their kids do better too. So when federal abortion rights disappeared with the overturning of Roe v. Wade this past summer, the implications were enormous. In particular, in particular for some of the most vulnerable people. This includes people without the money and resources to travel far to get care, as well as people who can't leave their jobs or their children to seek an abortion out of state. This map comes from the Guttmacher Institute. It's an organization which tracks statistics and laws related to abortion and contraception. The map shows how state laws are changing since Dobbs. The states in shades of blue have few barriers to abortion and sometimes even provide funding for it. From yellow to red, it gets more restrictive. Even if the state doesn't have a ban in place like Orange, Wisconsin, there are multiple restrictions that make it virtually impossible to get an abortion there now. So to date, as Miriam said, 13 states have banned abortion, most abortions. And in several more states, bans are blocked by the courts, but the battle is ongoing. Historically, abortion doesn't go away when banned. It has always existed and likely always will in some way. In fact, Latin America has an abortion rate that is similar to the US abortion rate, even though most of the Latin American countries have bans. People find a way, and some ways are safer or more feasible than others. So this map was just released from a study called We Count, and it shows that in the first 2 months after Dobbs, legal abortion decreased overall in the country by about 10,000. So specifically, abortions declined in the purple states by 22,000 in those first 2 months. But they also increased in the green states by about 12,000 in the same 2 months. The influx of these medical refugees into the green states increased wait times for everyone, while clinics worked to increase their capacity. Knowing this, we can speculate that people had later abortions than they would have otherwise in the last several months. Yet the decrease of 10,000 or so abortions doesn't exactly tell us what happened to those people. Certainly some are carrying the pregnancy to term. Other people are also increasingly ordering pills online. Fortunately, managing one's own abortion is physically safe using these pills because it is the same medication as prescribed by abortion providers within the health system. Self-managed abortion, although still not legal, has been studied and shown to be as safe and effective as in the clinic for early abortions. Self-managed abortion is likely to become increasingly common in the months and years to come, as it has been for decades in Latin America. It almost seems like a simple solution to the whole issue, but it's really safest for healthy people early in pregnancy, and it remains illegal. So that leaves people vulnerable to criminalization. And some people are more vulnerable than others, in particular women of color, who've been prosecuted far more. Still, it is truly an unprecedented time in medicine. For example, major medical associations have called for the decriminalization of self-managed abortion. Some medical associations even provide links to organizations like Plan C, shown here, that give information about how people order pills outside the medical system. Imagine that. We're talking medical associations are telling people where to find information about how to get pills outside the medical system. So where do Catholic hospitals fit into all this discussion of abortion bans after Dobbs? Well, most importantly, they've always had a ban on abortions in their institutions. In my qualitative research, I conducted lengthy interviews about reproductive care in Catholic hospitals with 56 patients and 47 providers around the country. When I first began interviewing providers, I was surprised to learn that they were limited by the religion of their hospitals going beyond abortion in ways they didn't expect. The most surprising to me was that they couldn't reliably provide treatment to a person actively going through a miscarriage. They told me in residency they were taught that there are 3 ways to manage miscarriage: with medication, with a procedure, or to watch and wait, if the patient prefers, meaning to give no treatment and see if the pregnancy can pass on its own, only intervening if it becomes dangerous not to. They were also taught that if a patient came to a hospital cramping and bleeding in pain, once doctors determined that the miscarriage is inevitable, that it's too late to save the pregnancy, they should provide treatment options. The standard of care is to allow her to choose between medication and a procedure to empty her uterus to get her out of pain and reduce the risk of infection. But in Catholic hospitals, they were not allowed to do that unless certain religious, not medical, conditions were met. If the fetus still had cardiac activity, which there sometimes is during miscarriage, in the Catholic hospital they had to wait. Treatment was considered an abortion, which they prohibit. The religious condition is you cannot treat to prevent danger. You must wait until the threat to her life is present. You can only do an abortion to save her life. What happens with miscarriage management and other pregnancy complications in Catholic hospitals relates to unfolding news about abortion laws generally. Since Dobbs, policymakers have publicly debated which exact medical exceptions to abortion bans should be built into the law. Just like the U.S. bishops, legislators who oppose abortion are setting policy about how medicine should be practiced. How much risk to a patient's life is required before she can get health care? And how, not just how much risk, but how urgent it should be. This is a tricky situation, to say the least. It's one that doctors in Catholic hospitals have been navigating for a very long time. And you would be right to ask, how have they made it so far all these years, given how dangerous it can be to deny treatment to people with pregnancy complications? And I'll do my best to give you a satisfying answer today. Catholic hospitals can teach us something, but not everything about the perils of medical care when abortion is banned. I say not everything because, as I'll show, Catholic hospitals have not existed without abortion. This is a false narrative. In reality, Catholic hospitals mostly displace abortion, burdening patients, providers, and other health systems in the process. But before we dive in, you need to know a few things about Catholic healthcare in the United States. Most people don't realize how much religion and medicine interact in our healthcare system. So I'll briefly address these 5 points. Starting at number 1, Catholic healthcare is a large sector of the healthcare infrastructure, treating 1 in 6 patients. Catholic healthcare is not a niche medical realm for Catholic people. In fact, they serve and employ people of all faiths throughout the U.S. The distribution of Catholic facilities is uneven. In 5 states shown here in red, over 40% of the beds reside in Catholic hospitals. In 52 rural communities, a Catholic hospital is the only option for care. There are other kinds of religious hospitals besides Catholic ones, but Catholic hospitals make up 3/4 of them. The remaining quarter of religious hospitals are diverse. They don't always restrict care at all per religion, but all Catholic hospitals must adhere to the same church policy. The U.S. Catholic bishops, the United States Conference of Catholic Bishops is the title, they write the policies that govern Catholic clinics, hospitals, and other health centers. And the U.S. bishops oversee all of the institutions. Their policies are called the Ethical and Religious Directives for Catholic Healthcare Services, and they include over 70 directives. The directives mandate that Catholic hospital clinicians restrict or prohibit certain treatments and services, including, of course, abortion, as well as contraception. Gender-affirming procedures can also be prohibited. The last directive on this slide, 53, represents a very common problem, that sterilization procedures such as tubal ligation aren't allowed, which many women request immediately following childbirth if they're done having children. Sorry. Put it over here. So even if a patient is having a C-section and her fallopian tubes are visible, the doctor must close her up without doing the tubal ligation that she requested due to the directives, requiring her to seek it later elsewhere. This is upsetting to the patients who are denied what they need and remain at risk of getting pregnant again, and it's distressing for physicians who know very well that it is less safe for her to have 2 surgeries instead of 1. Every surgery involves some risk of infection or anesthesia reaction. So it's not only substandard in modern medicine to require 2 surgeries when you could do 1, but far more burdensome when a patient is discharged home to take care of a newborn and possibly other children. Many simply can't make it back in. While Catholic hospitals are religiously and spiritually sponsored by church congregations and clergy, such as Little Sisters of the Poor, care is not financed by them. People often assume Catholic hospitals somehow deserve to be able to provide care their way based on a misperception that the money for care comes from the church. It doesn't. In fact, Catholic hospitals provide less care to the poor than average. Care is paid for by insurance, like Medicaid, which is public, or private insurance, like many of you have, and also government health care grants or aid. So they should be accountable to the needs of the public. Very few patients choose or seek out religiously restricted care. In a national survey I conducted with my colleagues in 2018, we found that 83% of Americans feel institutions should not be legally permitted to use religion to restrict care as they currently do. Do Catholic women feel any differently? No. Among Catholic women in our survey, only 3% reported that they intentionally seek a Catholic hospital, whereas 6% reported trying to avoid a Catholic hospital. This may be because, as mentioned earlier, Catholic people use abortion and contraception at the same rate as the general population and don't want religion to restrict their choices. So it's important to make clear that by enforcing the directives, Catholic hospitals are executing the will of the bishops, not the will of the Catholic people. And I want to punch this point home. My critique of Catholic governance in healthcare should in no way be heard as critical of Catholic people. Most people who identify as Catholic do not want to limit the freedoms of others in the same way Catholic leadership does. Finally, number 5, many patients can't avoid religious restrictions, in part because it's simply difficult to avoid restrictions that people don't know about. To start, it can be hard for some to figure out that the hospital's religious affiliations are even Catholic. So the names don't always sound religious. For example, Glendale Memorial Hospital, Northridge Hospital, Dignity Hospital. Those are all Catholic hospitals. In our national survey, over a third of women whose own hospital did not know it, and they did not know it, and the majority of those who could tell that a hospital was Catholic still didn't know which care was restricted. So even if people know their hospital is Catholic and they know about the restrictions and they want to avoid them, there can still be the problem of having no alternatives. They may not be able to go other places because of their insurance network limiting their options. They may not live near another option. So I write about how all these conflicts in care here in Catholic hospitals manifested and how they infringed upon patient autonomy and doctors. But today I'm just going to focus on pregnancy complications, miscarriage, and abortion. I'll start with Jaylyn's experience. She received miscarriage management consistent with Catholic hospital policy. Jaylyn had a pregnancy complication in her second trimester. She was 19 weeks pregnant. And it was before the baby could survive outside her body. She had started to cramp and bleed, and she was clear that something terrible was happening, so she went to the hospital. She recalled, "I was in so much pain. I was screaming, 'Please help me. I do not want to lose my baby.'" Doctors examined her and found there was nothing they could do to stop the miscarriage. Jaylyn was devastated, and by the time they admitted her to the labor and delivery unit, she had already spent 2 to 3 hours in the emergency room. She desperately wanted the physical pain and the emotional crisis to end. She recalled specifically begging the nurses at one point, "Can't we just get this over with?" And they were like, "No, because we're a Catholic hospital and we cannot assist in it. We have to wait until the baby's heart stops." So they hooked me up to a machine where we got to see and hear the baby's heart for like 8 or 9 hours. They apologized, saying, "We know this is hard," and that kind of thing. It was a very long night. Eventually her baby died. And only then was her doctor allowed to help move the delivery along with medical intervention. And the ordeal ended quickly from there. But she was emotionally distressed for quite a while after. What could have been over in an hour or two took 12 physically and emotionally painful hours, compounded by her constant awareness of the fetal heart monitoring the whole time. The outcome would have been tragic for her, whether her pain endured 2 hours or 12. But she was distressed that the religious policies added to her suffering. Being a religious Christian herself didn't reduce her desire for an emergency abortion procedure to end her pain. Looking back at what happened, she was still hurt and angry when we spoke years later. She said, to force somebody to continue to be in that state when the result is going to be more pain anyway, like, preserve my life right now. You already told me you can't preserve this life, so preserve mine. And part of that is limiting my trauma. She was denied the standard treatment options, and she had no idea that her hospital's religion could affect her in this way. Fortunately, Jaylyn never got infected or sick, as some patients do in Catholic hospitals while waiting, basically they're made to wait for the heartbeat to stop, as required per Catholic doctrine. Still, physicians working in Catholic hospitals worry about bad outcomes when religion restricts miscarriage management. To prevent the physical harm of infection and unnecessary pain and suffering, as Jaylyn had, doctors have a few common strategies. Some divert or transfer their patients to other providers in non-Catholic facilities. Some stretch the clinical truth to keep treating the patient in the Catholic facility, and many refer patients who are stable and not yet in the hospital to specialized abortion providers and clinics. My goal here is to show you how, despite the directives forbidding abortion and despite public statements by the U.S. bishops condemning abortion in all cases, Catholic healthcare cannot exist without safe abortion care. Catholic health systems are intimately linked to abortion providers because they depend on abortion providers to keep their patients safe and do what they don't. To explain what I mean by diverting, one OBGYN spelled out how he and his colleagues learned from experience to divert certain patients away from the Catholic hospital if they called in before going, because they call sometimes when they're experiencing symptoms of miscarriage and they want to know what to do. His doctor said, we figured out a pattern, right? So now, if a patient now has a problem, we discuss it with her before she goes to the hospital, the rules of the hospital. We don't have to deal with it as much as we did earlier on when it was our habit to say, go to the emergency room, or I'll see you at the hospital. Another described how his medical group transfers such patients to non-Catholic hospital. He said, we often tell patients that we can't do anything in the hospital but watch you get infected. We often ask them if they'd like to be transferred to a hospital that would go ahead and get them delivered before they get infected. It's just very difficult for them. They're already in a hard place. We actually have some of them discharge themselves, drive themselves, and then admit themselves to the next institution. I also spoke to a physician who told me how her patient had a liver transplant and became sick afterwards. Unfortunately, the immunosuppressant drugs she needed to take were known to cause birth defects. Additionally, due to her medical problems, being pregnant was physically dangerous for her. So this doctor transferred the patient's care to a different doctor who took her to a non-Catholic facility to do her abortion. She said, we could not wait until she was like 20 weeks and look at the baby and, make sure all the organs were okay. Just the pregnancy itself was going to be life-threatening to her because she had a liver transplant. So she needed an elective abortion at about 6 to 8 weeks. So my colleague took her to the surgery center, which is a short drive from the hospital, to do the abortion, which is not affiliated with the hospital. So in this case, the patient was not yet becoming ill or losing the pregnancy yet. So she didn't meet the life-saving criteria, but her doctors knew she was likely to become life-threateningly ill soon without the abortion. In other cases, doctors didn't transfer patients elsewhere, but they found a way to provide safe care by slightly stretching the truth, claiming that the patient's symptoms were worse or more dangerous than they actually were. Note, this is a risky thing for a physician to do because sometimes the staff person involved in the care might challenge them, causing the case to be reviewed and for them to be reprimanded by hospital authorities or possibly lose their job or worse, their medical license. However, and the license is only because if they're charting what is not true, that is not okay. However, some found it to be worth the risk. For example, a physician who had worked in both Catholic and non-Catholic hospitals compared the experience. And in the Catholic hospital, he said, you had to wait until they got sick, which was kind of foolish when you knew the prognosis was so poor. You have to wait until they got an infection. So if the temperature, normal temperature was 98.6, true infection's probably not 100 till 100.6, but we'd cut corners. So if they got to 99, we'd call it a fever. And we would induce them because we were protecting their life and trying to salvage their uterus so they wouldn't get a serious infection and need a hysterectomy. In addition to stretching the clinical truth, doctors found themselves sending patients directly to an abortion provider. Such referrals aren't officially allowed by the bishop's directives, which firmly and repeatedly prohibit association and cooperation with abortion providers. But they happen often anyway in practice. Many pregnancy complications, miscarriages, and ultimately abortions were managed by sending patients directly to family planning and abortion clinics. Sometimes physicians made a discreet verbal referral, instructing patients to go to a family planning clinic like Planned Parenthood. And such referrals were common for people who needed contraception and abortion and were medically stable, meaning safe to go on their own. This physician, who himself opposes abortion and works in a state where they've since banned abortion, explained how he walked the line of not formally documenting referrals to abortion providers, but just mentioning Planned Parenthood verbally with no documentation. We've tried to comply with the directives, and so mainly the workaround is I can verbally tell them, I can say, you go to Planned Parenthood. So making referrals discreetly or overtly was essential to physician practice in Catholic hospitals, despite the ambiguity about whether referrals would be policed as the clinical services were by the hospital. Ultimately, most doctors I spoke with tried to help patients who needed abortion find the care somehow. When a patient needed an abortion for a fetal anomaly, they typically receive more support and thus more medical assistance during the referral. That same doctor who opposed abortion said, if we have a patient who has a known anencephalic baby, a baby with, a brain that didn't develop, a fatal anomaly, and they want to terminate, then we refer them to a large southern city, and they can usually get them referred to somebody who can take care of that. I also spoke with an OBGYN who works in a Planned Parenthood in a region of the Midwest dominated by Catholic hospitals. He describes a reliable and formal referral process on the receiving end, and he notes that he's especially familiar with Catholic hospital OBGYNs because of their prevalence and the fact that their referral pattern is so consistent. He said, whether or not they're allowed to, we don't know. We get lots of paperwork from them because we, require is the right word, copies of ultrasounds that are done and genetic amniocentesis and that kind of testing and copies of prenatal records when it's available so that we can make sure we know exactly what we're getting into. And we've had virtually no problem obtaining that kind of stuff from them. So I hope by now I've answered the question of how Catholic health systems have grown and prospered if their religious policies prevent standard of care for certain pregnancy complications. By way of overview, ultimately in my book, I argue that reproductive care in Catholic hospitals is systematically less safe and less patient-centered. It can violate patients' reproductive autonomy and cause moral distress for providers who must lie or deny care. And additionally, the informal solutions doctors use to get patients what they need can exacerbate disparities. Provider racial bias and discrimination, which is well documented, may affect who gets that extra help, who the doctors will stretch the truth for. I'm deeply concerned about the potential for systemic discrimination built into a system that relies upon doctors taking professional risks to themselves in order to keep patients safe. Now that I've shared all of these clinical moments with you that involve sending patients of Catholic hospitals to abortion providers elsewhere, I want to remind you that these interviews took place before Dobbs. Some of these states now have bans on almost all abortion. Exceptions to abortion bans for the life or health of the mother are vague and insufficient. Many of the stories I just shared with you would have been life-threatening without an abortion at some point, but at what point? How sick should these patients need to get before they are treated? There's no other area of medicine in which we watch patients' health intentionally decline for religious, not medical reasons before helping them. Physicians in Catholic hospitals are doing an elaborate dance navigating when to divert, transfer, refer, or stretch the truth to keep patients safe. But now in states with abortion bans, some referrals to abortion providers are nearly impossible or illegal, or they may require patients to travel across state lines and sometimes several states. Further concerning, researchers have already noted a chilling effect on on appropriate medical practice in states with bans. So even for care that should technically qualify as an exception to the ban, doctors are afraid of criminal prosecution. In 6 states with abortion bans, Arkansas, Georgia, Idaho, Missouri, North Dakota, and Tennessee, providers can be arrested and can only use evidence to defend themselves, to show that the procedure was necessary to save the patient's life after they're criminally charged in order to clear themselves. That's a terrifying way to practice medicine. The medical literature is already featuring stories of poor medical practice in states with bans, like doctors either denying care or in dire emergencies giving women more dangerous procedures than they need in order to not appear to be doing an abortion. In Texas, where SB 8 was passed over a year ago, nearly banning abortion, RA and colleagues quoted a maternal fetal medicine specialist in Texas saying, "People have to be on death's door to qualify for maternal exemptions to SB 8. Another article in Pew quoted a physician saying, "It's happening every day. We're seeing treatment for ectopic pregnancies being stalled." That's a pregnancy that's not in the uterus, it's in the fallopian tube, and if left there could kill the woman, could burst. So we're seeing treatment for ectopic pregnancies being stalled until they rupture and become life-threatening. We're seeing people with broken water and fetal parts stuck in their vagina sent home until fetal demise occurs, or the patient ends up in the ICU because of infection and bleeding. Just 2 days ago, NPR reported that a woman in Ohio was sent home from the ER during a miscarriage to watch and wait, even though she'd been bleeding for weeks, and came to that ER that day because the bleeding had become much heavier. She insisted she needed treatment, but they were hesitant and clearly feared being accused of violating Ohio's abortion ban. At home, she hemorrhaged, passed out, and was taken back to the hospital by ambulance for life-saving care. So while my research on Catholic hospitals and all I've shared with you today tells us something about the gymnastics that physicians must do to keep pregnant women safe when they have medical complications in Catholic facilities, we are now entering into new territory post-Roe, where the old tricks don't necessarily work in all states. The safety valve that abortion clinics gave Catholic hospitals is gone, where states have banned abortions. Some doctors may still stretch the truth if they are willing to risk criminalization, but they won't have anywhere to divert, transfer, and refer patients within their states. What will happen now that Catholic hospitals cannot depend on family planning clinics to provide what they don't? This is a scenario we haven't seen yet. With this talk, I hope I've made it clear that just because Catholic hospitals have grown immensely and thrived in American medicine, they've never done so without abortion. They've only displaced abortion. They push the costs associated with denying that care, all of the physical, emotional, and financial costs of unintended pregnancy and birth, of abortion, of medical problems from delayed miscarriage management, onto patients and other providers. They have misled anti-abortion voters and legislators in pretending that medicine can be safe without abortion, but this has never truly been tested. So thank you, and I look forward to a discussion with you about many things that came up today.
Dr. Freedman for the really insightful talk. Now we'll be taking questions. So if you have a question, please line up at one of these 2 microphones and try to limit it to 1 question so we can give room for others to ask as well. And please introduce yourself before you ask your question. State your name, your year, your school, and yeah, thank you.
Hi, thank you for your talk. My name is Ari Levy. I go to CMC and I'm a senior. I really appreciate everything that you had to say today. My question is, You mentioned the strategies that Catholic hospitals use to diverge reproductive care, especially like abortion care. I'm curious to see how this affects other reproductive care, such as IVF, which is also similarly not really ethically accepted by the Catholic Church.
So it is also prohibited. And the way that I hear about it from doctors in a legal context, I don't know to what extent it may become banned in states that are banning abortion, but in a legal context, Catholic hospitals don't allow IVF in buildings owned by the Catholic health system. But what's kind of interesting about that is what they object to is, it's partly the embryos, but it's also the sort of premise of sexual activity happening outside the body. Like they don't want to remove the sexual act from sex. So, there are many objections to IVF within the Catholic Church. So I've talked to doctors who say that like the parts that are not allowed under Catholicism have to be done in other buildings, and they could still meet with patients in the Catholic buildings. So it was very like compartmentalized. And the doctors just said that the Catholic system wanted the money from IVF services because they're very, very lucrative. So they found ways to have the sperm removal, the egg removal happen in the non-Catholic building.
Thank you so much.
Fun stuff. All right.
Hi, Professor Freedman. I'm Wonder Wong, and I'm a CMC freshman. I think I have some question about the experience, this study you mentioned before, the survey that a longitudinal research about women who was turned down for abortion and women who accepted abortion. My question would be, you said at first they were at the same situation, same score at their relationships in life or whatever stuff, but do you think that there's a bias that for the women who are turned down for abortion because their pregnancy, the month is too much, and do you think that it is because, some characteristics difference about those females, like let's say like for more careful females who are more sensitive to their physical situation, and for female who are likely to be procrastinating, like their face was turned down of abortion, and that is actually the factor that affect the difference in the following development.
That's an excellent question. It's actually, and I'm not going to do this study justice because it's a huge study, and it's not mine, but I actually think I can answer that question. It's a really well-designed study because the women were actually very similar. Like, let's say the gestational limit was 16 weeks at the clinic, and somebody came in at 17 weeks, they got enrolled into the turn-away study. If they came in at 15 weeks, they got enrolled into I got the abortion. So they're very similar. They had to be just under or just over. And then they had a whole other group, a control group, that was people who got abortions in the first trimester. So that group of people were also compared so they could tell the difference between those people who came in early. So it's a really good methodological question, and I think they dealt with it really well, and I strongly recommend reading that book. It's pretty amazing. It's, like I said, 50 peer-reviewed scientific articles kind of all tied together in a really digestible way in that book.
Thank you so much.
Yeah.
Your lecture is very inspiring.
Oh, thank you.
Thank you, Dr. Freeman, for your talk. My name's Cindy. I'm a sophomore here at CMC. And my question for you is that I found usually when we are talking about reproductive rights, and just like the discussion and the audience that we're seeing here today, it's mainly made up of women or people who are actually experiencing this kind of reproductive restrictions by themselves. While you're doing your research, do you identify any gendered patterns in terms of if the Catholic hospitals are run by women versus men? Would it be more likely to practice safer reproductive actions, or are they going to be more bolder in terms of practicing such kind of miscarriage or whatever kind of situation they're dealing with?
That is such an interesting question. My answer is, I have to say, it's sort of like, I want to say it's sort of tentative, because it's not, I couldn't exactly observe. I was talking to individuals, But one thing that came up that was fairly gendered was that if a hospital was run by, like, some people talked about a particular nun in an older hospital who was kind of used to helping work these things out. They would talk about that. And then, but over the years, clergy have almost entirely left the hospital. So there's very few nuns, very few priests, very few. But there were some stories of like, oh, this nun or that nun used to run the ethics committee and she kind of knew what to do. And if we said it this way, she would approve the intervention. So there's something there. And also just as a more national level, the U.S. nuns have always been a little more liberal than the Catholic bishops, but they're hierarchically sort of under the bishops, so they don't have as much power.
Thank you so much.
Yeah.
All right. Oh, hi. I'm Amy. I'm a sophomore at Pitzer, but I was curious, you cited the statistic that Catholic women tend to be a little bit overrepresented in those seeking abortions. Do you think that has to do with the fact that the Catholic Church and a lot of Catholic schools don't teach quality sex ed and don't provide women with good resources for preventing pregnancy?
I think your guess is as good as mine. Yeah, I think that seems like a reasonable hypothesis that influences the numbers. There can be cultural things too. There's been a lot of research actually in recent years. Some of my colleagues have been researching like pregnancy intentions and how people decide whether to contracept or not. And there are some subgroups of people who don't want to use contraception, maybe because they didn't have good sex ed, or maybe because there's a lot of stigma around using contraception and knowing that you're going to have sex not to make a baby. So that could all be linked into cultural things. But it's also abstinence-only education, which we all know failed miserably. That's really common among sort of evangelical Christian communities as well, so it's not just Catholic. Thank you.
Thank you.
Hi, I'm Rachel. I'm a freshman at CMC. It seems like in your research you've spoken to many healthcare providers and doctors and practitioners of like reproductive healthcare. So how do you think the Dobbs decision will affect them, especially doctors who normally would be able to refer patients to get abortion elsewhere and now can't and have to watch them suffer? Like, what do you think they would do ethically?
I'm really curious about this. I guess I don't really have an answer. I mean, the people I know that actually provided abortions regularly and didn't work in Catholic healthcare, some of them are not working in those states anymore. They're just gone. But then I have not spoken with doctors in Catholic hospitals after Dobbs in those states yet, and I actually, my next project I probably will. And I'm really wondering, I'm kind of wondering if they may have some tools to use to get around the worst of it, or to save women's lives, because they've been having to navigate this for a long time, and that they're going to have to share those tools with the people who haven't been navigating this. I don't know, really.
Thank you.
Yeah, my pleasure.
Hello, my name is Johannes Brown. I'm a first year here at CMC, and I guess I could talk more about myself. Like, I'm from Georgia, so abortion is like a pretty like huge topic down there. So I guess like what trends do you see with like movement of people to like places that like it's more likely for like people to get abortion, stuff like that? You like have seen like post-Dobbs.
I'm sorry, I couldn't hear the last part. What did you say?
Like what movement trends have you seen from people to like get to states where it's able to like to get an abortion, stuff like that?
So what movement trends? How are you saying physically? How are people getting there?
Yeah.
Well, that's interesting that you asked that, because there are these organizations that are called abortion. They're basically raising abortion funds to finance travel. Now, it's hard for women to get that all lined up logistically and quickly, but there's a national hotline for abortion funds, and then there's regional ones. I'm pretty sure there's a Georgia one. There's definitely Texas ones. And so a lot of people who are pro-choice who have money have been sending money to abortion funds to literally finance travel and what it would take for those women. But I don't know if there's research yet on the impact and like I said, the one study I was able to report was from basically June to August. So we're just kind of, the data's just coming in. Did that answer your question?
Yes, ma'am, it did.
Okay, great, thanks.
Hi, thank you so much for your talk. My name's Kat, and I'm a sophomore at CMC. So my question's kind of two-pronged. If you're a woman in a state that has an abortion ban in a lot of Catholic hospitals, or if you're a woman who's seeking an abortion in a state with Catholic hospitals without an abortion ban, how do you go about receiving abortion care to ensure that your reproductive autonomy is followed? Are there steps you should take to see which hospitals around you aren't Catholic, or what would that process look like?
So you're saying, how could we advise someone to protect themselves from accidentally ending up in a Catholic hospital if they needed miscarriage care or an abortion? Okay. Yeah, and so it's actually not like so hard. It's just that people don't think to look. Like you can Google and say, is this hospital Catholic? You might get an answer. There's also a Catholic Health Association that has all their members. There have been a couple studies on how hard is it to figure out if your hospital's Catholic, how many clicks does it take? Because it's not always on the first page of the website. And in Washington State, they passed an actual law for every hospital to have to put on their website what reproductive services they offer or don't offer. And I don't know, again, does a person think to look that up when they're pregnant? But I think that's one little thing we can do is try to educate each other about that and about the fact that you might want to find out. And your sisters and cousins and friends might want to find out when they're getting pregnant.
Thank you.
Yeah, pleasure.
Hi, my name is Geeta and I'm a first year at Scripps. I kind of wanted to ask more about Plan C. Is it a viable option in the states that have like strict abortion bans, meaning like, are people prosecuted for it, and if or how are they managing that? Because you said it was like an online service.
Yeah, and it's not the only one.
Mm-hmm.
There have been various online services sort of cropping up. I don't know if any of you have ever heard about this, but starting maybe 15 years ago, there was Rebecca Gompertz. There's a documentary about her, Women on Waves. She created this ship out off the coast of Ireland before abortion was legal in Ireland to do abortions on this ship. It's a really great documentary if you want to see it. And so it was kind of really outside the box thinking. Well, anyway, that was a long tail that ended up with her realizing that the more practical way she could really help women access abortion was to mail them pills. So she started something I think called Aid Access, and I think that's hers. I shouldn't be talking about what I don't totally know, but Aid Access exists. It's a service that sends people pills. The pills come from India. They take a long time to get here. If somebody wants to get an abortion that way, it will take them into 2 or 3 weeks later gestation than they would like. It's not the best solution, but it's better than no solution. And for some women. And so Plan C is just one way of finding out about this, who's doing that. It's just like a resource. And I think a tiny bit of Googling yields a lot about what people are doing in terms of procuring medication abortion. But it's interesting because there has been studies of medical researchers have done studies where they ordered many from many different types of abortion pill vendors online that were all illegal, and they found that the medications were what they were supposed to be. And so that's why it's not the most, it's not considered a dangerous option physically, but it is still unclear whether to what extent people will be prosecuted. There's some research about how women have been prosecuted for self-abortion, self-managed abortion. An organization called If, When, How just released a study, and it's definitely, there's huge racial disparities in who are prosecuted, and that's very, very concerning. But the new abortion bans don't build in criminalization of women exactly, but it still could happen. So it's basically, again, uncharted territory. We don't really know.
Thank you for your time.
Yeah. Pleasure.
Hi, my name is Celeste. I'm a senior at CMC. Thank you for your talk. I'm from Washington State, and over the last decade, I've certainly seen a lot of our hospitals get bought up by Catholic institutions. And so I'm wondering, first, if you imagine these numbers on the right increasing over time, and then also, what is it about these Catholic institutions that allow them to monopolize hospitals in their communities? Do they have a lot of private funding that's giving them some sort of hierarchy or economic superiority over hospitals that allow them to buy it up? Or I'm just having a hard time imagining why hospitals who don't have Catholic values are okay with Catholic institutions buying them up and making these changes.
It's a good question. I would start with, it's just a ruthless business, healthcare in this country.
Yeah.
I'd just start there. And so, I mean, in Seattle, you know, just they just keep having these, somebody buys Swedish and then they sell Swedish. It's Catholic, it's not Catholic, it's just about money. It's about who has more capital at the time. And I can't answer the finance question in great detail, but it's a really interesting one, and I really want someone to research it, because I'd say that the consensus among people I know who study this is that basically Catholic health systems have done very well by consolidating and partnering with each other, and the Catholic Health Association helps them communicate and find each other, find good partners, and it has been very lucrative for the health systems to get big. Right. We already know that it's actually not helpful for the patients. They always say if we get bigger, and I'm talking about every health system, not just Catholic ones. They always say if we get bigger, we can, save on costs, and then the care will get cheaper. But it never gets cheaper. So they get bigger and bigger and bigger. And Catholic health systems are very large. The top 10 health systems in the U.S., 4 of them are Catholic. So they're very, very large. And so I think that part of the success may have been the partnering with like-minded people who really want the deal to work, and they've been match-made by the Catholic Health Association. That might have given some advantage. Otherwise, it's just, they're not funded by any religious organization, as we know. It's just business.
Yeah. Thank you.
Hi there, my name's Brian Davidson. I advise students on fellowships here. I figured I'd ask a question since the students seem to be done. I'm just curious from a comparative perspective, the rates on the right there, do you have any idea what Catholic health systems look like outside the US? And I'm thinking particularly a place like France, for instance, where abortion is legal. Sure, there's restrictions and whatnot. I would imagine, historically it's a very Catholic country. I'd imagine that there's a Catholic healthcare system. Does the same kind of stuff happen?
I don't hear about it. I'm not an expert on the international context, but I don't hear about it. I think this is a little bit more of a product of our capitalist sort of free market-ish health system. So I think, in other countries they have more, socialized medicine and government-provided care. So there are Catholic hospitals, though, everywhere. I know that in Chile they're considered like the best medical schools and providers of healthcare, and they exist in many places. I don't think they're just as uniform and as like centralized as our giant Catholic health system under the U.S. bishops are. The other thing is I have heard that they are not always as extreme as ours in terms of policy, because perhaps just we're the U.S. and we do things in extremes, I think I've heard in some European countries, maybe even Italy, that there's not near as rigid of a sort of policies. But I'm conjecturing beyond my knowledge.
No, that's really interesting. Thank you.
Thanks.
I actually also have a question.
Great.
So I was wondering, like, some of the examples you gave and also some of the stuff I've been reading in the news, it seems like doctors, when approaching uncharted territory or unclear laws, they always go on the side of, like, being extra safe and, like, taking, like, what they assume to be the strictest version of the law. And I'm just wondering, like, why do you, is that an accurate representation of what yeah, okay. And then why do you think that happens? Like, why does it seem like a lot of American doctors, like, just, like, I don't know, like, why do they, like, follow like the strictest version of the law when it's like unclear anyway?
Because they don't want to be sued or arrested. Those are the big ones. I think a lot of doctors live with fear of malpractice suits all the time, and it's really, I mean, in obstetrics, it's been an issue for ages that because obstetric lawsuits are so expensive and so dramatic and so scary, that doctors will, you know, I mean, one of the big issues of our time was, you know, excessive C-sections. Doing C-sections when they really don't need to because they're really afraid they'll be sued if the baby doesn't, you know, come out well if they wait. And so, sounds simple, but really you're having a lot of women have surgery that don't need it. So this is just a very common issue in medicine. So then you add it to this context, and that's where you're talking about the chilling effect on practice, where we're seeing women who definitely qualify for an abortion under the ban be not treated because they're afraid. So yeah, it's a concern, and I think that I would add all that the incredible amount of time and money that goes into being a doctor makes doctors incredibly conservative about not losing their, you know, income and privileges. So yeah, does that do it? Okay.
Hi, thank you so much for being here tonight. My name is Charlie Hatcher. I'm a sophomore here at CMC. You mentioned that some of the really restrictive policies that govern Catholic hospitals are put in place by the Catholic leadership, and that's actually out of step with what Catholics at large think these policies should be. So I'm curious what you think the prospects for, you know, closing that gap are in the future, and yeah, are there any indications of discontent that, you know, this might not be something that Catholics are okay with, their leadership taking this more extreme position?
Well, I would say that, you know, there's the very place to start with that is there's an organization called Catholics for Choice. And all they do is try to communicate with Catholics who would like to see change, and they do a lot of research and advocacy. So that's just the formal sort of mechanism for that voice, that advocacy voice. But I do wonder, though, I mean, a couple days ago they announced that there's a new president of the U.S. Conference of Catholic Bishops, and that person that was appointed is on the far right, someone who really dislikes Pope Francis, is a very extreme anti-LGBT rights, anti-abortion, really wants them to focus more there, whereas Pope Francis had said, let's focus less there and more on social justice. So it doesn't seem like the U.S. Catholic bishops want to move to the left at all, but the nuns do. And so what's going to happen there? And I mean, it's my secret hope that the nuns will start their own religion, but I don't think that they're gonna listen to me. I don't know.
Thank you.
Not really a secret anymore. All right, are we good? Thank you so much.
Yeah, thank you again to Dr. Freedman for her amazing talk and for answering all of our questions.
Thank you for having me. This was really, really fun. So, and what a lovely evening. Thank you.
Thank you all for coming, and I hope you all have a great Thanksgiving break. And I hope to see you at our lunch events later this semester, but this is our last formal dinner. So yeah, thank you for coming, and come next semester.